Very fortunate to have folks from the state here to give a regulatory update, Michelle Chan and Julienne Tran. Michelle is the Quality Assurance Pharmacist with the Board of Registration in Pharmacy, and Julienne is a Pharmacy Investigator with the Board of Registration in Pharmacy.
My name is Michelle Chan, and I'm here with Julienne Tran. I am going to share my slides and so that we can get started. So again, I'm Michelle Chan. I'm the Quality Assurance Pharmacist with the Board of Pharmacy. And today we're going to provide a regulatory update for the things that have been going on in the past few years. Julienne and I have no conflicts of interest, and we're not going to discuss any investigational or unlabeled uses of any commercial products. Our objectives are threefold today. We're going to talk about the differences between legislation and regulations, and go over the process to implement new and revised regulations, as well as go over and summarize some new advisories, policies, and circular letters. So before we get started, we kind of just want to go into a little bit about who we are. So there's board staff and there's board members. I'm just wondering, if anybody really knows the difference. So Julienne and I are full-time employees. We're board staff. We do things such as licensing, inspections of pharmacies. We do educational programs such as this one. We help people through pharmacy renovations. We do all sorts of things on behalf of the board. The board members are appointed by the governor. They're unpaid volunteers that help us out at least once a month. And they make the final decisions on the cases and the applications and everything that we bring forward to them on a monthly basis. They also make the final decisions on regulations and any policy documents that we bring forward. So the board has jurisdiction over individuals, but not hospital pharmacies at this time. So anything that has to do with individual licensure, such as ratios, those still apply in the hospital setting because those are geared towards the person, not necessarily the setting. The board also does not have jurisdiction over insurance, payments, customer service, or labor issues such as lunch breaks. Just so that you're aware, soon, we're actually hoping soon that we'll be licensing hospital sterile compounding facilities. That hasn't happened yet, but we're hoping it'll happen soon. So the pharmacy board makeup is 13, the lucky number 13 individuals on the pharmacy board. The majority of them are pharmacists. And the pharmacists come from a variety of different backgrounds, bringing their individual expertise to the decisions that are made at the board meetings. So we're also lucky enough to have a pharmacy technician who brings also a different perspective. And for the past several years, we've had some really great pharmacy technicians on the board. We also have 2 healthcare professionals, a nurse and a physician, as well as 2 members of the public who have healthcare background. Board members have 3-year terms, and they are permitted to have 2 consecutive terms, so a maximum of 6 years in a row. If they want to have another term, they would just need to wait 3 additional years between terms, and then they can be reappointed. Standards of Patient Care Initiative, which we also call SPICY. We started doing these SPICY meetings during the height of pandemic when things were a little crazy. There were a lot of illnesses. Pharmacies were closing because they didn't have the staff. So we wanted to touch base with pharmacy organizations as well as pharmacy leadership of corporations to try to see what we could do to make things a little easier on the pharmacists on the front lines. So when we had all these conversations, we did find that there were things that we could help out with. And some of these are temporary measures, and some of them are actually still in place. So for instance, the ratios for pharmacies who are actually administering vaccines, the ratio is 6:1. So one pharmacist could have up to 6 support personnel if they're administering vaccines. Also, perpetual counts are required less frequently at this time. And we also allow a manager of record of one store to be a temporary manager of record of a second store if that second store is having difficulty finding a permanent manager of record or needs a little bit extra time before they can get one into effect. The nice thing about this meeting is that we were able to help out When the inspectors go in and they saw a huge line, they were able to have a greater access to pharmacy corporate, so that we could get some help in there to loosen things up for that pharmacy and help them catch up. One of the other things that had come out of this is the non-sterile compounding policy that we have in place. Recently, the USP 795 that had come into effect was a lot more strict than we had anticipated to begin with. It seems to have been geared towards pharmacies that have non-sterile compounding as their core business. So we have been talking with pharmacy corporations to just try to figure out how we can adjust those for the typical pharmacy retail setting. So for instance, there is a requirement in USP 795 that, the walls and the ceilings have to be clean. Well, the document that was released that the board approved last week actually said that, as long as your pharmacy is clean, we don't intend to enforce the cleaning of the walls and the ceiling and that sort of thing. So that was another great thing that had come out of those spicy meetings. So we have all these terminology that, that we throw around. Many of us are not attorneys. So we're going to go just briefly talk about the differences between regulation and legislation, and also those things that we call advisories, policies, and circular letters, and try to give you a little perspective on how they affect your life. So the difference between legislation and regulation. So legislation is also known as a statute or a law. And in our case in Massachusetts, it's MGL or Massachusetts General Law. So when the legislature passes a law, it generally only provides a basic framework of what they want the requirement to be. It tends not to have a whole lot of detail, and it just kind of gives not the nuts and bolts, but just the basics. And that's where the regulations come in. So the regulations in Massachusetts are CMR, or the Code of Massachusetts Regulations. And what they do is they effectively put the law into effect. So you can think of the law as what, and the regulations as the how-to. So the regulations, give the details on how to carry it out, how to, all those details that would not be appropriate for the law. One primary difference between legislation and regulations is that legislation cannot be waived. The board doesn't write it, and they have no authority to waive it. Though they do, because the regulations are written by the board and board staff, the board does have authority to waive those if they see fit. So for example, it is in legislation, it is in state law that all pharmacists have to have 20 CEs every single calendar year. So other states have 40 every 2 years. Our state is 20 every calendar year. And again, that's in law. It's also in law that if you do sterile compounding or complex non-sterile compounding, that you have to have 5 and 3 CEs in that area as well every calendar year. Again, so the board cannot waive those compounding CEs unless the law is changed at some point. Where the regulations come in is the board has additional requirements, such as, the 2 of law that are required every year and the 5 live and other various things that are outlined in the regulations. Promulgation of regulations. So this is a fairly long process. So once a law is passed, it falls to the board staff to develop regulations. So we write those regulations based on input that we can get from stakeholders or from other states who have put something similar into place. After the board reviews it and approves it, it can go out for a public comment period. So all of the public is invited to give input to the draft regulation, and then the board will take all those comments and consider what changes they would like to be implemented or made, and then they'll approve the final draft. And then eventually those new regulations are published and implemented. The thing that delays things is that there are a few times in this process that the regulation has to actually go up to the state executive offices to make sure that the regulations don't bump up against any other laws or regulations. So we want to make sure that the process is smooth. So that's why it takes a little time sometimes to get through the process. As far as the public comment period goes, the link will be on our board's website. It's on the draft regulations page. It will be by the end of the week. I'll have it on the draft regulations page so that you can see when the public comment periods will be. So public comments can be made by anyone. It can be made in person or in writing, but we always prefer it to be in writing to make sure that we don't mishear anything during the public comment period. Okay, so this set of documents is called advisories, and advisories are, in general, they're non-enforceable and they contain best practice recommendations. They also give recommendations on how to meet certain requirements that may already be in place. So for instance, we have the advisory on information from managers of record. So we all know that managers of record have a lot to do. They have several more responsibilities than other pharmacists do. And they need to make sure that, pharmacy and the personnel licenses are up to date, which is no small feat for personnel licenses because the technician licenses all expire on their birthday, whereas pharmacy and the pharmacist license all expire on a specific date every other year. The scheduling always has to remain within ratios. The pharmacist to technician ratio always has to be adhered to, and that's the manager's responsibility as well. Being prepared for inspections, having one spot for all of the inspectional materials. If the manager is organized and the material is all in one spot, when the inspector comes in, they can just get as much material as they can from that one spot without having to interrupt the workflow of the pharmacy. There are also a lot of board notifications, including drug losses, serious adverse drug events, defective drugs. So hopefully, for the most part, this managers of record advisory addresses most of that. There's also the individual requirement for when you leave a manager of record position to notify the board. You just send the board an email saying, I am leaving the manager of record position of this pharmacy on this date. And that's very important for you to do, because when you leave that position and if for some reason the new manager and the pharmacy don't submit a change of manager paperwork, then you're still going to be on the hook if you don't notify the board that you've already left. So this is just something to keep in mind to protect yourself when you leave a manager of record position of a store. USP 800 in community pharmacies. So USP 800 is not a compounding chapter. It's the chapter that talks about handling of hazardous drugs. So this chapter applies to all retail settings, all healthcare settings, including retail pharmacy. So, compounding pharmacies are already pretty good. They already have pretty much know what they're supposed to do for compounding of hazardous drugs. So this guidance document is for non-compounding pharmacies. So when the inspector comes in, what they're going to be looking for is just that you have a written, well thought out program as to how you're going to be handling hazardous drugs in your pharmacy. So they want to know how you're going to identify your hazardous drugs, whether you have anti-neoplastic drugs, reproductive risk only drugs, how you're going to store them, what you're going to, what PPE you're going to use when you count them out, when you put the order away for storage and handling. All of these things you just need to address in a formal hazardous drug program, because we want to make sure that everybody does it the same way in that pharmacy. We also have several sterile compounding advisories. So for instance, the smoke studies in isoclassified areas. So this one will go over how to use the airflow pattern information that you've received when you've done some smoke studies in those areas. Action level, environmental monitoring and remediation considerations go through how to handle when you have microbes or particulate levels that are action level under USP. Things to look for, things that you might consider might have been the contamination source. We also have one on failed HEPA filters. So we talk about the risk assessment. So when you discover a failed HEPA filter, how to assess the risk for the products that have been compounded since your last certification where your HEPA filters were still intact. HVAC excursions, we recommend having excursion limits that are alert levels and action levels. So you can tend to see if something is drifting towards something that is going to be a problem. If you have an alert level, you can hopefully catch it and remediate it before it gets to an action level and you wind up having to take your compounding room out of service. And media fills, we talk about incubation and proper technique on that particular topic. Policies are considered sub-regulatory guidance. These policies have required information and they're enforceable as well. So the first one is a new policy for this calendar year. It is actually a revised policy. So it's 2024-01, which involves naloxone dispensing. And the reason why we redid this one is because you probably know that naloxone has gone over the counter, but there still exists some prescription products as well. So people can still obtain naloxone by using their insurance and having a prescription filled through the pharmacy. So these are the same parameters that we had in place before. You don't have to put the patient's name and address on there because that person may be giving it to someone else for use, but they can certainly use their insurance to pay for it. The link to the standing order is in this policy, but DPH is still in the process of updating that standing order, and it will be linked to this policy as soon as it's completed, just so that you're aware of that. And also, please encourage the retail front store to have a location for over-the-counter naloxone, as well as you having some behind the counter to dispense with a prescription. DPH would like to make sure that naloxone is readily available and on the shelves and wherever it can be. Unfilled prescriptions. So the DEA had come out with a rule last year about unfilled prescriptions, and they will allow any unfilled electronic Schedule 2 through 5 prescription to be transferred to another pharmacy for an original fill. So on a Friday night, if you get a prescription for oxycodone and you don't have it for some reason, you can transfer that prescription electronically to another pharmacy who does, so that they can fill it for that initial fill. The DEA only allows it for unfilled electronic prescriptions. If you've gotten a paper prescription and you took it in and put it on hold and you want to transfer it to another pharmacy, you cannot do that. You can't do that with any of the federally controlled substances. With Schedule 6, which is Massachusetts Schedule 6, we do allow you to transfer any unfilled Schedule 6. So if you took it in and put it on hold and the patient wants you to transfer it, even though it hasn't been filled yet, you can certainly go ahead and do that. As far as the federally controlled substances, you can transfer those unfilled prescriptions once. You can't do it more than once. But you can still transfer the refills once as well. So it's maximum of twice. The technology does exist for pharmacies to be able to transfer these unfilled prescriptions, but the DEA has acknowledged that certain pharmacies may not have coordinated with their technology vendors to update the systems yet, but the technology is there and the pharmacies just need to update it. Schedules 2 and 3 quantity limits. As you know, Schedules 2 and 3 are limited to 30-day supplies, and that's in state law, except for 2 conditions, except for narcolepsy and for limited brain dysfunction. So what this policy does is defines limited brain dysfunction as ADD or ADHD. So for these 2 diagnoses, you can dispense a 60-day supply, and you can dispense any of the mixed amphetamine salts or derivatives. It doesn't have to be limited to just one. I believe that the statute actually says Adderall, but you can use with any mixed amphetamine salts or derivatives. You do have to verify the diagnosis, but you only have to do that once. So if you have a patient coming in continually for, to have scripts filled for narcolepsy, you can continue to fill it. The diagnosis does not have to be on the prescription in order for you to fill it. In light of the stimulant shortages that we're having, the drug control program is allowing prescribers to issue paper prescriptions for the stimulants, so patients can go from pharmacy to pharmacy and not have to worry about the pharmacy transferring an electronic prescription. Just so that you're aware about that. Continuity of care. Again, this is one of those Sunday night things where a patient comes in and they want a refill for something that doesn't have refills. You can issue a 30-day supply or the smallest available package size for a C6 drug. So except gabapentin, everything is except gabapentin. If they don't have any refills and you can't reach the prescriber in a timely manner, you can give a 30-day supply as long as you document the reason. This can only be done once. It cannot be done more than once. If a prescriber is no longer practicing, say they've retired or moved or passed away, you can continue to fill any prescriptions that were issued when there was a valid patient-prescriber relationship. So if there are any refills on a Schedule 3 through 6, you can go ahead and fill those. If you have multiple prescriptions for a Schedule 2 that, up to a 90-day supply, you can also go ahead and fill those as well. They're still considered valid. Control-19 COVID control measures. And last year a new law had come out talking about COVID control measures, such as COVID-19 tests, drugs, and other diagnostic devices that have been approved by the FDA. So this new statute allows pharmacists and interns only to administer tests and drugs that have been approved by the FDA for the treatment of control measures. I do have this example here as vaccines, but vaccines are kind of a different story here. So I'll talk about that in a minute. But in general, pharmacists can administer these drugs as long as they're sub-Q or IM, so they cannot administer anything that's IV. Okay, so vaccine administration. So there have been an update to the regulations that now say that qualified pharmacy personnel can administer ACIP vaccines to patients as young as 5. And that includes RSV. So qualified pharmacy personnel now include pharmacy technicians that have certain training and experience. So qualified pharmacy personnel would include a pharmacist, intern, and certain technicians. Even though our regulations have changed now down to 5 years old, the PrEP Act still supersedes state regulation. So you can still immunize down to age 3 until the end of this calendar year, which I believe is when the PrEP Act expires. Should it expire before then it will default back to the 5 years. The training will is similar for technicians, interns, and pharmacists. CPR certification and ACPE immunization training are required. Technicians must also have 2 additional hours of on-the-job training with a certified immunizer. They also must be nationally certified or have at least 500 hours of having worked after receiving their PT license. And just to clarify the duties for a pharmacy technician administering vaccines, they can only prepare and administer the drugs. The drugs still have to be selected and approved by the pharmacist. And as with pharmacists, they still need to have some sort of continuing education training every 2 years. Continuing education, this is one I like to talk about in every CE because we still get a lot of questions regarding continuing education programs. So as I mentioned earlier, 20 CEs are required every calendar year. 5 of them have to be live, 2 of them have to be law. The law does not have to be live, and there's a maximum of 8 hours per day. Acceptable credits would be ACPE and ICPE. ICPE is they provide joint accreditation for several healthcare providers, and ACPE is a founding member, so we'll accept those credits. AMA PR Category 1, that's one type of physician credits. Those are accepted. Category 2 are not acceptable. And if you have any that are approved by United States Board of Pharmacy, those would be accepted as well. I don't know if any pharmacy boards are still approving programs at this point. Massachusetts does not. But if you do have some, then those would still be acceptable. This policy also goes over the duties that would require specific credit hours. So, who has to have the sterile compounding CEs or the complex or the immunization or CDTM. For instance, the sterile. In order to be required to do the sterile, you would have to be, actually physically compounding. You'd have to be supervising someone who's compounding or checking products that someone has compounded. Those duties require you to get those specialized CEs. What counts as a compounding credit? So ACPE does have a compounding code, but it's not specific for sterile or complex non-sterile. So you can't depend on that as being the end all be all as for what would count for a sterile credit or a complex non-sterile credit. So the program titles have to say something like sterile or IV or USP 797 or 795. But if you do come across a program that you really think should be considered and it doesn't have one of these keywords, feel free to let us know. Send us an email and we can have a look at it. Scope of practice is another important policy that we have. We are trying to put as much as we can into this scope of practice document so that we can capture as much of pharmacy practice as we possibly can. But this policy is not going to be all exhaustive. This is intended to be a living document, so as practice evolves, we can add things for technicians and pharmacists alike. So for instance, we have all the technician information here. Pharmacists can administer certain injections, but they cannot administer all injections. They can't administer penicillin skin tests. They cannot administer B12 injections. Pharmacists can't recommend OTC medications for animals. OTC medications are indicated for humans, and a pharmacist shouldn't be recommending those for animals. And diagnosing is not in a pharmacist scope of practice either. You can obviously offer symptom management for a patient, but diagnosing is out of the scope of practice of a pharmacist. Compounding copies of commercially available drugs requires 3 things in order for you to be able to do it. So you have to have a patient-specific prescription, and there has to be a unique medical need that the prescriber deems is required for the patient to have a compound, and that medical need has to be documented. So for instance, now that omeprazole suspension is a commercially available product, you can no longer compound it. Unless it meets one of these criteria. If the patient has an allergy to a dye in it or an excipient, you can no longer compound it on an ongoing basis. It being cheaper to do that way is not a significant difference, and the FDA would not allow you to continue to compound it. Which prescription changes and additions. So pharmacists do have, as an independent authority, to change a day's supply in their professional judgment. Again, it's only for C6s that do not require PMP reporting, which means you can't change gabapentin. So if you get a prescription for amlodipine for a 1-month supply with 11 refills, you can dispense a 3-month supply with 3 refills if the patient wants that, or if insurance covers that sort of scenario. We do recommend using extreme caution with behavioral health drugs and narrow therapeutic index drugs, just for patient safety reasons. There are concerns. We have received some concerns from some prescribers who have had their patients have a 3-month supply of mental health drugs, and they have had concerns for their safety. One thing that you can now add also, this policy has been updated to allow pharmacists to add flavoring for C6 medications. So you can change the prescription and add that on without proper prescriber approval. Okay, this next set of documents are called circular letters. This circular letter is essentially a policy through the Drug Control Program, and the Drug Control Program is a sister agency to the Board of Pharmacy, and they handle, basically the implementation of the Massachusetts Controlled Substance Act. So, their jurisdiction covers, the format of a prescription, electronic prescribing, and all of that falls under their purview. So obviously some of these things affect pharmacy as well. So the first circular letter is about contraceptive prescribing. So this is a fairly new law that has gone into effect. So pharmacists now may prescribe contraceptive pills or patches, whether they're OTC prescription, and you can do it for any age, or whether they've had a prescription before or not. It's not a requirement for pharmacists to prescribe contraceptives. This is merely a pathway to do it if you choose to. You will need an NPI number. And in this circular letter, it does explain how to get an NPI number, but in MCSR, a mass controlled substance registration is not needed. which is unusual because every other prescriber in the state needs a mass-controlled substance registration. But in order to allow people to do this more easily, it was decided that an MCSR was not going to be needed for a pharmacist to perform this service. You will need to register with MassHealth as a non-billing provider, and the due date for this is May 1st. There have been some glitches in the system, but registering with MassHealth as a non-billing provider has to happen by May 1st. There is a required training program, and there's also the requirement for a patient self-screening tool. Maryland has a great tool. If you look at the resources at the bottom of this document, there's a link to men's resources, and they have a really good self-screening tool that you can use if you want to. Out-of-state prescribing, out-of-state C2 prescriptions, and supervised prescribing. Out-of-state prescriptions can now be filled from any authorized non-resident prescriber. So it used to be you could only take a Schedule II prescription from a physician. So that changed a few years ago. You can take it from anybody now who's an authorized prescriber. However, the rules for out-of-state prescriptions have not changed. So an out-of-state C2 is still only good for 5 days, and you can still only take a narcotic prescription from a contiguous state. But you can now accept an Adderall prescription from a nurse practitioner in North Carolina. You can accept an oxycodone prescription from a dentist in Rhode Island. So these, some of the rules have changed, but not all of them for this particular situation. Nurse practitioners also, some nurse practitioners also now do not have to have a supervisor, which obviously would make it difficult for them to put the supervisor's name on their prescriptions. So because it's some nurse practitioners and not all nurse practitioners who have to have a supervisor, the decision was made that a pharmacy could fill it with or without a supervisor's name on the prescription. So it's the nurse practitioner's job to know whether they have to have their name on the prescription. But as far as filling it, you don't need it. You don't need to check for it, and you don't need to verify whether they have to have it there or not. It's still considered a valid prescription, and you can fill it without that information. We also have an electronic prescribing and dispensing manual, which is really good because it kind of gives all the nuts and bolts about e-prescribing. There are a huge number of e-prescribing exceptions. And when we talk about e-prescribing, we're talking about e-prescribing. We're not talking about e-dispensing. So prescribing has a lot of exceptions, but essentially it is mandated for a prescriber to prescribe electronically. And I'll get into that in a few minutes. I'll get into failovers as well in a few minutes, but a failover can be accepted as an oral prescription for any drug, any C6 other than gabapentin. And there's also this ancient law in the books that requires you to sign across the face of a Schedule II prescription. The mere act of verifying the prescription meets this requirement. So there is no need to print it and sign across the face of it. So what a failover is when an electronic script for a Schedule VI fails to transmit electronically properly, and it arrives in the pharmacy as a fax. And you'll be able to tell that it's a fax because it won't have a proper signature on it. An electronic signature is only valid when you're going from one electronic system to another electronic system. A fax, when you receive a fax, has to have a handwritten prescription on it. So if you receive one of these things and you're otherwise comfortable with the prescription, you can go ahead and fill it as an oral prescription. It's not considered a written prescription because it doesn't have a signature, but if you're otherwise comfortable with that, then you can accept it as an oral one and fill it as written. If you're not, you can always just call the prescriber and say, I got this, did you send it, and can I fill it? One thing I really want to drive home is that electronic prescribing, again, is prescribing. There are a whole bunch of rules about prescribers and the requirements they need to meet. But as far as you filling a prescription, nothing has changed. You can continue to fill a valid written or oral prescription without having to verify that the prescriber has a waiver or that any of the other scenarios exist. You can always fill a handwritten or paper prescription or an oral prescription. And the reason for that is simple. You don't want the patient to be stuck in the middle of trying to figure out this sort of stuff. This is, lessons learned from other states that have implemented e-prescribing before. And the regulations do allow you to dispense it, so there's no need to worry about not getting reimbursed or that sort of information or that sort of scenario. Circular letters, again, come from the drug control program, and this is the director and his contact information should you have a question about the circular letters. We also have something on the books called the Access Law, and this is access to birth control and emergency contraception. So this went into effect about 2 years ago. So birth control, you can now fill a 12-month supply. So not all insurers and not all birth control products can be filled for a 12-month supply. But if a patient comes to you and says, I want a 12-month supply, just verify it through the insurance. If insurance covers it, then you're good to go. The restrictions for 3 months or 1 month or whatever, those are generally insurance driven. They're not driven by any regulatory or statutory limits. So you can go ahead and fill a 12-month supply, and if the insurance will cover it. Emergency contraception also, this is, again, for most part, it's no cost, but again, that's not all the insurers. But there is a statewide standing order that explicitly has the which tablets, which pills you can dispense, as well as anti-emetic that you can dispense for the patients. There is a yearly reporting requirement to the sexual and reproductive health program, but this again is not a requirement for you to dispense. It is something that you can offer to your patients, however. Okay, at this point, I'm going to turn it over to Julienne to talk about the inspection side of things. Julienne, do you want to share your slides, or would you like me to keep going with the slides? I think you're muted.
Would you mind just advancing for me?
Of course.
So the next piece is just some of the things we've seen. The investigators have typically conducts over 2,000 inspections annually. We do inspections for the 795 compounding pharmacies, the 797 sterile pharmacies, and also including the community pharmacies as well. This list of deficiencies and area of improvement really haven't changed much from year to year. It just, depending on the year, one of these may be more higher on the list. But the typical things that we do see in the pharmacies, including perpetual inventories, not having a complete inventory record, not including expired medications that you are sending out to the reimbursed distributor. If it's expired, that needs to be included on your perpetual inventory until it leaves the pharmacy. Biennial inventories are something that you should have readily available. One of the items that the investigators will be looking for and on the checklist is a copy of the biennial inventory. Documentation, just for ease of use, for many pharmacies, is having an organization tool, binder, a box that you have all your documentation that you should have readily available for the investigators when they come to do an inspection. And again, in the retail compliance inspection is available on the board's website. There's no secret to it. It's all the different checklists and the checkpoints that the investigators use to review and look over our pharmacies are readily available on the website. So I suggest and recommend that you take some time and print out a copy and review and make sure that your pharmacy is in compliance with it. I always find that it is a helpful task to involve the pharmacy interns. Perhaps they could use it and use it as a learning tool when they are on your rotation with you to go through the checklist and make sure that you have all the records and materials that would be required during a retail compliance inspection. We also see many issues with refrigerators not having complete records. If you are immunizing at your pharmacy, it is required that the temperature is monitored at least twice a day, and also initialed of who is completing that. You want to make sure that you delegate and have a person or various staff if there's a sick call to be in charge and responsible for recording the temperature. Many of the pharmacies now have automated 24/7 temperature recording. But if there is a, if the temperature goes down, you'll have to make sure that there is a backup plan and that the temperatures for the refrigerator and also if you carry any frozen products, the freezer is monitored on a daily basis. And then also pharmacy staffing. You want to make sure that you adhere by the pharmacy ratio, 1 pharmacist to 3 support personnel, 1 of which is either a intern or a certified pharmacy technician, or of 1 pharmacist to 4 support personnel, which 2 are a more advanced certified pharmacy technician or interns. And then also having complete compounding records. If you engage in 795 compounding or 797 compounding, you just want to make sure that you have complete records of the dispensing, also the labeling requirements that are required for as part of your compounding records. And again, having it readily available if the investigators need to complete an audit of your compounding records. Good. Advance, Michelle. And then additional deficiencies that we have also seen is compounding copies of commercially available drugs. If the patient is unable to use a commercially available product and they have an example, need a prescription in another dosage form, you want to make sure that the prescription clearly indicates the need for why you need to compound and make a copy of the commercially available product. So it has to be some sort of documentation from the pharmacist, the doctor, that there's a specific need. If there is a patient has an allergy to a red dye and they get anaphylaxis, that needs to be clearly documented on the prescription. And then you want to make sure that if they continually get it over years, that there's some sort of documentation within the hard copy on the prescription or a electronic note in the pharmacy software to indicate the indicated need for the copy of the commercially available product. Having incomplete records. So if you dispose of compounded preparations of the active and pharmaceutical ingredients, that you have complete copies of that, invoices, and that there's a reverse distributor or somewhere you're sending to. At no given time should API products be thrown out with your regular trash, which we have also seen as well. So you want to make sure that you maintain and keep those records within the pharmacy. Also, one thing that we have seen particularly over the past year or two is having unsecured medications. So we understand that many pharmacies are engaging in immunization for their patient, which is wonderful and great, but there is construction for immunization rooms now within many pharmacies, that there is extra space to provide private immunizations for patients at the pharmacy. The immunization rooms are not considered licensed space. So if patients have access to that room, that is not licensed space. So as a result, you cannot store any immunization supplies, you can't have any immunization drugs there, you cannot have refrigerators or freezers with any medication in immunization rooms because they are considered unlicensed space. because patients have access to it. Additionally, Michelle had touched upon it at the beginning of the presentation, but manager of record change notifications. We have been seeing untimely manager of record change notifications, and we understand that manager of records may have different opportunities and move on, but it's important to provide notification if you are no longer the manager of record at your pharmacies within 10 business days to the board. And for those manager of records who are moving on, you will need to personally send an email to the Board of Pharmacy to let us know that you have moved on and you are no longer at ABC Pharmacy number 1 and you are moving to DEF Pharmacy number 2. And then additionally, all the documentation and paperwork regarding manager of record change, including the controlled substance inventory, needs to be completed when the manager of record moves on, and needs to be co-signed and dated by the incoming manager of record. And those documentations need to be readily available within at the pharmacy during an inspection. Additionally, we have seen that pharmacy technician and pharmacy technician trainee licenses are expired. Their paperwork is not current, and those pharmacy technicians are practicing without a license because there wasn't a compliance program in place to keep abreast of the license expiration. So we can't recommend enough that there's additional a compliance piece, especially when there's a change of manager of record, that you want to make sure that all of your staff, pharmacists, interns, pharmacy technicians, and pharmacy technician trainee licenses, that there is an understanding of when their expiration date of their license is, so that they can be compliant and maintain up to date in good standing. And, perhaps you have something in place where there's every month checking or quarterly checking, so that that compliance piece is in place, so that you have licenses that are current and up to date. And additionally, licenses need to be posted within the pharmacy as well, in addition to if you engage in immunization, CPR licenses also need to be available and in date for the investigators when they go on site. We can advance, Michelle. So some of the things that we have seen, so in this picture you will see at a pharmacy, this was a picture of a pre-filled unlabeled syringe. Not sure what was on the right-hand side. Syringes can't be pre-filled, it has to be immediate use. So we do not recommend having pre-filled syringes in place like this. Next slide. Again, another copy, a larger zoom of the product, and you may see the vial in there, but again, this is you can't pre-filled syringes like this. This is considered compounding, and syringes, immunizations need to be done when the patient is there for immediate use. Can you advance the slide? So this is a picture of a refrigerator, and you will see black mold that is growing in this refrigerator. So you want to make sure that you take a look at your equipment, the freezers and the refrigerators, that they are maintained just like any other piece of equipment in your pharmacy, and there needs to be a cleaning schedule to address any issues, especially black mold like this. The next picture is a pharmacy, is the bathroom attached to the pharmacy space, and the black item on the floor we call it crud as a technical term, is dried up sewage in the bathroom. Again, that needs to be cleaned and addressed. Next slide, Michelle. And as you can see there in the highlighted red circle is this area is considered the hazardous drug area. And as you can see, there is food in addition to excess paper in this area. And the next slide. We want to let you know that the Department of Public Health is sponsoring 1 CE credit in order to provide training for healthcare providers on, caring for patients with disability. And this does offer AMA PR A Category 1 credit, which does count as part of the CE requirements for the year, and as Michelle touched upon with the CE policy. And just as a friendly reminder, 2024, this is the year for pharmacist license renewal. So everybody who is here and attending has gotten a leg up with at the end of the CE today that you'll be getting 5 CE credits, but this is 1 CE additional credit that you can participate in, and you want to just make sure that you save the certificate for at least 2 years in case of an audit. This, because it's a AMA PR Category 1, it will not just transfer automatically into the CPE monitor. And you will need to complete the questions at the end of the videos to receive CEs. And advance the slide. So the next set of questions are the assessment questions for a presentation. So this assessment question is, how many boards of pharmacy members are pharmacists? So the majority of the participants with 41%, 8 is the correct answer. We do have, the total board is made of the lucky number 13, and 8 of those members are pharmacists. And if we can advance the slide, Michelle. So who may make comments to propose regulations? A, the Attorney General, B, professional pharmacy organizations, C, pharmacy technicians, or D, anyone. So, and that is correct, 93%, anyone. D is the correct answer. So anyone can provide feedback and comment to our proposed regulations, and we urge you to keep updated on the Board of Pharmacy websites for any upcoming regulations that we may need public comment for. And the next slide, Michelle. Who can receive naloxone under the statewide standing order? So A, only the patient taking the opioids, B, family member of the patient, C, friend of the patient's, D, any person in a position to assist with a potential overdose, or E, all of the above. That is correct with 86%. The correct answer is E, all of the above. And the next question, you'll have to take a look at the prescription on the right-hand side. So how can this prescription be dispensed? Select all that apply. A, dispense as written, dispense a 3-month supply, or dispense a 12-month supply with no refills. So the correct answer is all of the above, so A, B, and C. So as Michelle had mentioned, the Access Law MGL Chapter 118E, Section 10K requires some Massachusetts insurance plan to cover a 12-month supply of birth control, so it could be filled all at once. You can also, change the quantity for a 3-month supply with 3 refills. And then also, it can also be filled as a single fill for a 12-month supply under the permitted pharmacy changes policy that was discussed. The next question, now that e-prescribing is mandatory, what should you do if you received a handwritten prescription? A, fill it only if it is a Schedule 6 drug, contact the prescriber to see if there's a waiver, or C, fill as written if the prescription is otherwise valid and appropriate. And majority, 94%, chose the correct answer, and it is C. We could fill the prescription as written because the prescription is valid and appropriate. Additionally, we wanted to make everyone aware of the Pharmacy Substance Use Disorder Program, which is a confidential program for patients who are pharmacy licensees that have a substance use order involving alcohol or drugs, for patients who want to join this program. The information for our PSED supervisor at Taglieri is listed below if you want additional information. Next slide, Michelle. So the Board of Pharmacy does have a website, and there is a lot of updated information on there. All of the advisories and policies are listed, including current and draft regulations, and this will be the information point for any public hearings that may be open for public comments for draft regulations. And the website is there for you. The next slide, Michelle. The Mass Board of Pharmacy also has an APP newsletter that's available that highlights all the different information and compliance that are up to date within the state. And we highly recommend that you subscribe on the distribution list so that you have access to the NAPP newsletter with all the different current informations that we have. Next slide, Michelle. Again, additional information regarding the Board of Pharmacy contact information is below, including our website and email for any practice-related questions. We also invite all of you pharmacy interns or any pharmacy technicians that want to view what a Board of Pharmacy meeting is like. Our Board of Pharmacy meetings are the first Thursday of every month, and they are virtual now for the time being. And it is also available on the Board of Pharmacy website. And the next slide, Michelle. And also here are all the different references that we had discussed today, including all the policies, circulars, and advisories within the presentation today. Also, as a note, an important note for those in a dispensing role, that beginning March 4th, so next month, generic Flovent will require a prior authorization for those patients on Mass Health for patients greater than or equal to 5 years of age. Mass Health doesn't have a conversion chart. So you want to start to, begin initiating change or coming up with a plan. And again, additional information is on the Mass Health website. Mass Health is a sister agency, and we're just providing that information so that you are all aware. But any information regarding Flovent and prior authorization, please refer all questions to the Mass Health group. And with that,
well, thank you, Michelle and Julienne. That was wonderful. There are actually a ton of questions, but we don't have all that much time. And I see, Julienne, you answered some questions in the chat.
yes.
But there are still quite a few.
Julienne, do you want to just take a few, and then as we can just continue to answer questions in the chat during the break?
Sure. Let's see.
Here's one about, are phoned-in prescriptions for gabapentin allowed, or must it be faxed, written, or electronically prescribed? So prescriptions for gabapentin can be accepted in any form. It can be called in, faxed, and electronically prescribed. Any one of those is acceptable for gabapentin. The only different thing with gabapentin is that it has to be reported to the PNP, but otherwise you can accept the prescriptions as written.
And then a while back in the chat, someone asked if the original prescription is electronic, but the store you are transferring to can only accept via fax. Is that permissible?
Only for Schedule 6. You cannot transfer a federally controlled substance in any other way other than electronically. Sorry, it's fairly hard to page through all of these.
Yeah. There's also questions in the Q&A.
Oh, okay, maybe that'll be easier to look through.
Yeah, the last few.
Let's see. Can you clarify mixed amphetamine salt and derivatives for 60-day supplies? This includes any stimulant. Yes, that's correct. It includes any of the stimulants, Vyvanse or any of the methylphenidate products. It includes all of those. AMA Category 1 doesn't get submitted to NABP CPE monitor like ACPE credits do. I do keep records, but hate when my total isn't over 20 in the system because I did AMA credits. Are there concerns from the board about this? If you are audited by the board, you will just need to produce the paperwork. You'll be asked, and we won't just go through what's in CPE monitor because we are aware of people that have other things other than what's in the CPE monitor.
I think there's another question, Michelle, that regarding someone who's the CEO of a home infusion company that has several sterile compounding. Will they be required to have any sterile CEs if they're not mixing or monitoring himself? So in the CE policy, you need to have sterile CEs if you oversee or engage in sterile compounding. I don't, we can't go through everybody's job description, but if you engage or oversee sterile compounding in any of that process, including doing data entry or the verification of the product, even one time during the year, you will need to engage in sterile compounding CEs.
There's one here about the that hospital pharmacists, manager record changes from hospitals are communicated. Unless you're licensed by the board, there is no requirement to notify us of those changes. So no,